this presentation in this webinar with MAICO. I'm just going to give it about 30 more seconds as we have quite a few people just entering into the webinar. So I'll give it 30 more seconds and then we're going to get started. Okay, well, let's get started. We have a good group together here today for this presentation. Thank you for joining MAICO for this World Hearing Day and this webinar on how to improve ear diagnosis in children. My name is Carrie Browning, and I will be the moderator for this webinar. It is a pleasure for me to introduce our speakers. The first is Dr. Jeff LaCour. He is a board-certified otolaryngologist, currently practicing in Hammond, Louisiana for over 10 years. Dr. LaCour identified a critical need to bridge the gap between specialty and primary care, creating greater collaboration across disciplines. Combining this vision with his passion for teaching, he founded Compasio Medical Education in 2021 to equip healthcare professionals with practical skills and foster stronger cooperation throughout the medical community. And the second presenter is Dr. Gabrielle Merchant. Dr. Merchant is an audiologist and hearing scientist and the director of the Translational Auditory Physiology and Perception Laboratory at Boys Town National Research Hospital. Her laboratory has a particular focus on pediatrics, conductive hearing loss, and wideband acoustic emittance. She is passionate about her work and efforts that will support the translation of these measurements to clinical practice. Before we begin, there's just a few items to remember. Please know that this webinar is being recorded for future review, and we will be providing it at the end of the presentation. We'll be emailing it out to everybody. I'm sorry, I missed our presenters right here. So Dr. Jeff LaCour and Dr. Gabrielle Merchant. And then just if you would like to have live captions with this presentation, you can certainly do that. Just go up to the top of your bar and select on the More icon. And then from there, you can select the language and speech, and then the live captions, where then you can select your language that you would like to have. And lastly, just so you know, we will be having a Q&A session at the end if time allows. And if you could, throughout the presentation, go up to the top icon and select the Q&A icon and type in your messages, then we will be able to answer those questions at the end of the presentation. Now, I would like to turn it over to Dr. LaCour as our first presenter.
Great. Thanks so much, Carrie and Dr. Merchant. It's great to join you. So yeah, this is definitely a passion of mine. So my hope for today is to raise awareness of the international problem we have with ear diagnostics when it comes to just using otoscopy alone. When it comes to diagnosing acute otitis media and otitis media with effusion or just fluid behind the eardrum, using otoscopy alone is not enough. And what I really want to drive home today is raise awareness of this, okay? I want to show how inconsistent and how inaccurate we are as a country, as an international community when it comes to just using otoscopy alone, and the need we have of having an objective point of data in addition to otoscopy to improve our diagnosis, okay? And then my hope is to inspire all of you to become part of the solution, to realize that we need otoscopy plus tympanometry, which gives us that objective data and helping solve this problem. So what I want to do first is look at this study, okay? This study says it all, okay? Back in 2015, there was 222 clinicians at 25 different sites, okay? These were all pediatric providers, okay? They looked at the most common reason children were seen and treated with antibiotics. And what they saw was that the most common reason was acute otitis media. It shouldn't surprise any of us, right? It was the most common reason, most common diagnosis, and most common reason for an antibiotic. And then what they did was they standardized patients for age, sex, race, and socioeconomic status. So basically, let's call him Billy. If Billy went into clinic A, how was Billy treated? And then if Billy went into clinic Y, how was Billy treated? Same patient, different clinicians, right? So let's look at the data. If Billy went into clinic A, this is the how often he was going to be diagnosed with acute otitis media and given antibiotic. But if he went to clinic Y, there was a almost 3 times more likelihood that he would be diagnosed with acute otitis media and given an antibiotic. So this data should shock you, right? That means there's a 300% variance. These are clinicians all under the same umbrella. But if Billy went to clinic Y, he was 300% more likely to be diagnosed with acute otitis media and given an antibiotic than if he went to clinic A, okay? This highlights how wide of a variance we are. So in diagnosing acute otitis media. So who's right? What if these folks are right down here? What if the clinic A where they're below 10? What if the ones at below 10 are actually the more accurate ones? Or what if clinic Y is more accurate? My point in presenting this is that we're not consistent in diagnosing this, and it's so subjective to what we're seeing. And I'm going to highlight that otitis is all these providers are using, and that's why there's such a wide variance. So next slide, please, Carrie. And if you could click on that. So what this shows is this is a 1-year-old, one of my patients with acute otitis media, and you can see that bulging tympanic membrane. And if you can actually see the pulsations of the eardrum from otitis media, okay? These are not the ones we're missing, right? If the child's like quiet enough and calm enough to let us look, we see this. This is an easy one, right? And if you can click on the next one. All right, these are also pretty straightforward, right? We're looking there, the left tympanic membrane, there's a fluid, there's a meniscus of fluid right there. We can see that, we can even see a bubble. And the one to the right, that's a very obvious amber effusion. We look at that, we compare it to the other side. That's pretty straightforward. Okay, but what about these next slides? So these are tympanic membrane. These are all of my patients, right? So I'm looking at these slides. I'm looking at these eardrums with a high definition scope. Okay, I'm about 3 or 4 millimeters away from the eardrum, and all of these folks, you can't really tell what's behind the eardrum. So let's start with the top left. Okay, that patient was presented to me and was told that they have fluid behind the eardrum, and it looks like fluid. It looks like there's bubbles behind the eardrum, right? But what that is on the eardrum is that's actually something called laryngosclerosis, which is calcification of the eardrum, and it's giving the illusion that there is bubbles behind the eardrum. So that's actually not fluid. The middle one at the top row was presented to me as a cholesteatoma. Okay, that's actually just more aggressive laryngosclerosis, and there's actually nothing behind the eardrum. But can we really tell that there's nothing behind the eardrum with otoscopy alone? The top right was presented to me as an eardrum perforation. Okay, well, we used some tympanometry on him and proved that there was not a hole in the eardrum. We'll get to that in a little bit. Bottom left is a tough one. That's a lot of laryngosclerosis. My nurse practitioner thought it was a TM perforation. It's not a perforation. And actually, there's nothing behind the eardrum. But how can we tell with using otoscopy alone, right? The bottom middle was a lot of scarring, tough to see what's behind it. Okay, I had to use tympanometry in order to see that there's nothing behind the eardrum. And we'll get to that in a bit. And finally, the one to the bottom right, I was convinced had an ear infection. The eardrum's red. You can see the umbo's pretty red. The eardrum itself is pretty it just doesn't look like it would move very well. But sure enough, I got tympanometry on this patient, and it was a type A tympanogram. So my point in showing this slide is no matter how good your otoscopy, no matter how good your scope is, there's these new scopes that are very high focus and very good images, but it doesn't really matter how good it is if you don't have an objective data of showing you how the eardrum is how the eardrum is moving, you truly can't tell what's behind these eardrums. So next slide, please. So now I want to show you just what exactly tympanometry is. And if you can turn up the volume, please, Carrie. I think you might be on mute, Carrie. Still not hearing anything there. Sure. I think if
We might have to share sound.
so, I think you're still on mute, Carrie.
It should play when I'm playing through there, but let's try this again. I apologize.
And no worries if it doesn't work out. We can.
We'll try one more time. Give me one more try.
So what we have here is a tympanometer. A tympanometer is able to tell us the status of the eardrum as well as the status of the middle ear. Is there fluid in the middle ear, or is there a hole in the eardrum, or is it intact? And what we have here is basically a little probe. For adult patients, we have bigger probes, and for pediatric patients, we have smaller probes. And what happens is we'll put the tympanometer into the ear canal, it'll send a wave or a sound wave, and it'll record the movement of the eardrum. What I want to do now is we're going to basically elevate the helix right here. We're going to go in, and I'm going to point it right towards the nose. So he had a nice type A tympanogram. What that means is his eardrum is intact, there's no fluid behind the eardrum, and there's no hole in the eardrum.
Great, thanks, Karen. You can do the next slide. So the nice thing about tympanometry is your medical assistant can do it, the person who rooms your patient can do it. It takes about 10 to 15 seconds, and it's tolerated quite well, okay? And literally, it takes, like, literally, you saw how long it took. It took about 10 seconds to give us a tracing. And how complicated is it? How hard is it to interpret the results? It's pretty simple. So top left is a type A tympanogram, okay? And there's an eardrum that goes with it. What that means is the pressure in the ear canal is equal to the pressure behind the eardrum. So when you get a nice peak, and that just shows how the eardrum is moving, okay? If you see a nice peak like that, it doesn't matter what the eardrum looks like. There is nothing behind that middle ear. And guess what? All of those 6 eardrums from my previous slide had a type A tympanogram. So as gnarly, as bad as they looked, those had nothing in the middle ear, okay? Type C is more of a retracted tympanomemory, and that shows this is a retracted TM, the second one. And what that means is there's negative pressure behind the eardrum in the middle ear space, and so that eardrum is retracted, okay? The third one is a flat tympanomemory, and what does that mean? That means that the eardrum does not move. When the pressure goes into the ear canal, the eardrum doesn't move. So basically, it's just a flat line, okay? And then what if there's a hole in the eardrum? Well, it makes sense. It's not going to move as well, so you're going to get a flat line. But notice the volume. There's a volume 4.83 right there versus 0.51 in the previous one, okay? Once you get at about 2 mLs, 2 milliliters, if it's greater than 2, it's adding the ear canal volume plus the middle ear canal volume. And so being greater than 2, that gives you the assurance that there's a hole in the eardrum, or if the child has a tube, which is patent, that means that the tube is patent, or AKA a hole in the eardrum, okay? But this is it. This is all you need to know, okay? If it is flat, there's something behind the eardrum. If there's a peak type A, there's nothing behind the eardrum. If it's a retracted type C, then the eardrum is sucked in. Yes, children can have a problem. They could have some hearing loss from this, so that's something to be aware of. But it gives you that objective data rather than just looking and hoping that your eyes are getting it right, which we just saw is not that accurate. Next slide, please. All right, so in America, and this is, and I state this, the guidelines I'm using and the studies I'm using, these are American studies, but this is an international problem. Like talking with colleagues, this is all over the world, right? But what does the American Academy of Pediatricians say when it comes to diagnosing acute otitis media? They say that clinicians should not diagnose acute otitis media in children who do not have a middle ear effusion based on pneumatic otoscopy and or tympanometry. Well, pneumatic otoscopy is great. Hopefully we've seen that, or maybe we've used it ourselves. Pneumatic otoscopy is great. The problem with pneumatic otoscopy is sometimes you don't get a good seal and it's still kind of subjective. Okay. I know myself, if I don't get a good seal and I puff some air in there, if I don't see movement, it doesn't mean that there's something behind the middle ear, in the middle ear. It just might mean that I just didn't get a good seal. But tympanometry gives me that objective data. Next slide, please, Carrie. All right, so in both of those, pneumatic otoscopy and tympanometry are the only two ways to actually check the mobility of the eardrum, okay? How are we doing? How is our country doing in the US? Not too well, okay? This study back in 2019 was a retrospective study, and it looked like 474 cases of acute otitis media. And what it showed was that only 28 of the 474 cases actually mention the mobility of the tympanic membrane. So that means that less than 6% of cases use either tympanometry or pneumatic otoscopy. And if we don't have to, but if we go back to that initial study, this is why there's this huge 300% variance of what providers are calling acute otitis media or not. And guess what? Otitis media with effusion or just middle ear fluid is actually more misdiagnosed than acute otitis media because you don't have that purulence to go by. It's just kind of this bland fluid, right? So my hope in presenting this is that we truly need guidance. We truly need another point of data to help us make these diagnoses. Next slide, please. All right, so why are we missing these? Okay, there's a couple reasons, right? A child, when we look, if a child's crying, imagine this. We've all seen a 2-year-old child who comes in with fever, tugging at their ear, and when you look, they're kind of crying or they have been crying, and you look and the tympanic membrane is red, right? Well, the tympanic membrane becomes red whenever a child cries. So the Pediatric Infectious Disease Journal said we should check the mobility. We should use pneumatic otoscopy or tympanometry, right? And what about that child that gives us just that half-second look? They're angry, mom or dad's trying to hold them. We're not getting a good look. I get this all the time, and we don't get a good look. We might see a red tympanic membrane, and that's it. More than likely, we're going to give them an antibiotic if we're just going from that look and mom and dad's perspective that they're miserable, they're febrile, and so, but that's not good enough. The good news about tympanometry is that children tolerate it very well. It lasts a few seconds, and it's almost like a little thermometer probe where they sit there and they're not feeling like the provider's coming in at them. The provider's standing upright, and they tolerate it quite well. Next slide. All right, what about otitis media with effusion or serous otitis media? Dr. Merchant's going to get into this in the next part of the webinar, but the Otolaryngology Society in America says clinicians should obtain tympanometry in children with suspected otitis media with effusion for whom the diagnosis is uncertain after performing pneumatic otoscopy. We already talked about that. Not too many people use this, but the point of this is it is strongly recommended. Why is this strongly recommended? If we're not certain, and if we're honest with ourselves, we're not certain a lot, right? I know I'm not, and I'm not casting stones. I use tympanometry 3 to 4 times a day and have been wrong numerous times on what I thought I saw with otoscopy, but what it actually was, okay? But why does our academy strongly recommend this? It has to do with the developmental delays that Dr. Merchant is going to get into if we miss this and kids are living with fluid behind their eardrum. Okay, next slide. All right, so what are the numbers, okay? Otoscopy alone, sensitivity and specificity for middle ear effusion, so there's something behind the eardrum, is around 61%, okay? The sensitivity and specificity for tympanometry has been quoted at 90% and 86% respectively. Sensitivity and specificity for pneumatic otoscopy, 93 and 58. But then when you combine otoscopy plus tympanometry, the sensitivity and specificity goes above 90%. And this was my point earlier. We need an objective point of data. And otoscopy is great, but when you add that to tympanometry, your confidence, that wide 300% range will narrow like this if this becomes standard of care. Next slide. So this is a study we did out of the University of Colorado, and it was an urgent care. And this data is being presented at a conference, at the national conference this May. And what we did was we looked at ear patients coming into the urgent care, okay? And we looked at, did tympanometry change our diagnosis and did it change the treatment? And out of 116 patients, when the device was used, the test was used, it changed the treatment or the diagnosis 60 times. That means 52% of patients had either their treatment change or the diagnosis change. And then when we looked at antibiotic prescribing, if you use the tympanometer, 75.6% of patients were given an antibiotic versus 91.8% if we didn't use the tympanometer. What that shows is we naturally want to please. We naturally want to please the parent. We naturally want to please the patient, but we might be pleasing them with the wrong diagnosis and an inappropriate antibiotic. And so, for instance, in children, when they come in and they're having ear pain, one of the most common reasons for ear pain when someone has something going on in their throat is referred otalgia from throat pain. Okay. So that's one of the things that this just shows that if we started doing this, we would be shocked how much this would change our practice. Next slide. All right. So how does this work? What if there's cerumen in the ear canal? What if there's a tube in the ear canal? If the ear canal is still open about 30 to 40%, the tympanometer will still work. You can see this is one of my patients. His tube was extruded. I wasn't too sure if there was something behind the eardrum, so I went ahead and got a tympanogram. Let's take a look.
This is our sweet 4-year-old patient who has a history of tubes times 2. Okay, so he had recurrent serous otitis media, which was causing a hearing loss. So he got tubes, but unfortunately, when he came in today, the tubes are out, and I couldn't tell if he had fluid or not. So we went ahead and did a tympanogram, and we can see a flat type B tympanogram. A lot of times when patients have had tubes or even just earwax, you can't tell if there's fluid or not, but the tympanogram will usually be able to tell, is that fluid or is that a type A normal tympanogram? So his is a flat type B, so we know he's got fluid. So it's important for me to see him within 3 months to make sure that fluid has resolved. And if it hasn't resolved, then he needs a hearing test to see if he needs another set of tubes.
And Dr. Merchant will get into that in a little bit. So, but you can see that I couldn't tell. And so the tympanometer was able to give me a tracing. So I knew, okay, I need to see him back to make sure this is gone. Next slide, please, Carrie. And this is my sweet child. This is one of the ones I was talking about before. 2 to 3 days of fever, pulling at ears, irritability at night, nasal congestion. I got less than a half-second look. Eardrum was red. I wasn't 100%. So she let me put the tympanometer in there, and it gave me a flat type E tymp. So yes, this was her fourth otitis media. So she did need ear tubes, but let's take a look at her.
All right, so we have this sweet 1-year-old patient who has now had 4 episodes of otitis media. And when I looked in there, she literally gave me about not even a half a second look on each side because she didn't like it, okay? So I wasn't sure. I saw erythema of the tympanomembrane on both sides, but it wasn't bulging or anything like that. So to confirm that, I went ahead and got a tympanogram, okay? The tympanogram gave me a type B tympanogram on both sides. I don't know if you can see that. A type B tympanogram on both sides. So why does that help me? Well, now I know she doesn't have a red eardrum because she's crying. That actually is erythema and otitis media with a flat B tympanogram. So yes, she's had 4 episodes of otitis media in 1 year, so she does need ear tubes, but this is key. If you can't get a good look in a child's ear, this is key to confirm the presence or absence of something in the middle ear.
So every ENT and audiologist I've spoken with doesn't understand why this isn't standard of care in every pediatric practice, primary care practice. We use it as ENT and audiologist all the time. And our hope in this message is we need to do better as a world and as an international community of getting the appropriate patients antibiotics and getting the appropriate patients tubes. A lot of times patients are getting tubes that shouldn't be getting tubes because they're being diagnosed with all these not real otitis media infections, okay? So I'm going to turn it over to Dr. Merchant to kind of give you some of the downstream effects of this.
Well, good morning, everyone. Thank you so much for letting me be a part of this webinar. I'm really excited to be here and to have the opportunity, along with Dr. LaCour, to talk about the incredible importance of doing tympanometry and getting our diagnosis of otitis media right. And so, as Carrie mentioned in the nice introduction, I'm an audiologist and a hearing scientist, so I really think about this from a slightly different perspective than like a medical ENT might. And so while Dr. LaCour, I think, really beautifully highlighted the importance of getting the diagnosis right, particularly in terms of antibiotic stewardship and things like that, the sort of angle that I think about it more commonly is thinking about the hearing loss that can be associated with otitis media. So otitis media can cause hearing loss in children. And in fact, it's actually the leading cause of hearing loss in young children. And as Dr. LaCour mentioned, we have these clinical practice guidelines in the US. And the one specific to tube placement, actually, or in thinking about management of otitis media, say that if a child has otitis media with a fusion that persists for 3 months or longer, they need a hearing test. And that's because we're acknowledging that these children can have hearing loss. And so what I'm going to share with you today are some data that sort of highlight why thinking about that hearing loss is important and why getting our diagnosis is right. You can go to the next slide, Carrie. So you see 3 images here. The one on the far left is just sort of a schematic of what an audiogram is. This is while we look at and sort of plot hearing loss as audiologists and ENTs. And so what you see is on the x-axis at the top there, we're going from low to middle to high pitches. And so we usually try to test along the range of frequencies or pitches that we're hearing. And then on the y-axis, you see it going from soft sounds down to loud sounds at the bottom. And so someone with normal hearing is going to have sort of X's and O's, if you will, or different markers in that yellow normal hearing range, which means that at all the different pitches, they can hear very soft sounds. And as we see increasing amounts of hearing loss, we have to turn the volume up for kids to hear it. You're going to see those marks get progressively lower on the graph. And so in the middle, what you see here are different responses from both children who do not have a history of ear infections or any recent otitis media, and those are the marks you see in black. Then the other 3 sets of data are from children with different types of otitis media, or actually in this case, different amounts of fluid in their middle ear. But the take-home message I want you to see from this is that in comparison to kids without otitis media with effusion or a recent history of that, the kids who have had a recent history of otitis media or still have some fluid in their ears all have poor hearing. And so there are a couple groups of kids where they have a little bit less fluid in their ear, so they still have fluid, but it's not completely full in the middle ear. And those kids sort of have this borderline mild slight hearing loss. There are actually some kids you see in sort of teal or green there that by the time they had tubes placed, there was no longer any measurable fluid in their middle ear. So we call those ears clear. Those are ears that maybe didn't perhaps need to have those tubes placed in the end. But they still are sort of on that borderline normal hearing loss. So they're still not hearing as well as their normal hearing peers. And the kids that, sort of really jump out at you are those ones that are way down on the plot. So those pink ones. And that's a pretty common presentation, especially in kids getting tubes where they have quite a bit of hearing loss. So that's a 40 to 45 dB hearing loss. That's a moderate conductive hearing loss. Those kids are hearing kind of like it sounds like they're underwater. So that's going to be really noticeable to them. But the take-home message here for us today is just how much hearing loss is possible and sort of anything in between this range if a child has a flat tymp and some fluid in their ear. And so again, that picture on the right is just to highlight, normal speech is around 45, 50 dB, depending on the child. And so if the softest sounds a child is hearing are at 40 to 45 dB, they're not getting much out of even sort of an average conversational speech level. It's a pretty notable amount of hearing loss. You can go to the next slide, Carrie. The other thing that I think about a lot and that I think is important to be aware of is that the hearing loss and sort of fluid in the ear are super variable in these children. And that can really influence, I think, the downstream effects. And again, make sort of highlighting why our diagnostic precision in monitoring this is really important. You can't tell any of this variability from looking in the ear alone, but otitis media diffusion can occur in one or both ears. And in fact, there are studies that show that what's happening in one ear is not correlated with what's happening in the other ear. So maybe you get a good look in one ear, but you don't get a good look in the other ear. You don't know what's happening in both ears. Even if it's present in both ears, it can be really different between the 2 ears. So you could have a partial effusion in one ear with just a little bit of hearing loss and a full effusion in the other ear with a lot of hearing loss, sort of again, and everything in between. And we see a lot of asymmetry between the ears in these kids. The hearing loss can have differing amounts of severity. You can see, again, differing amounts of severity on other sort of parts of the spectrum of this. The characteristics, the viscosity can be really different. The amount of effusion can be really different. And all of these characteristics can fluctuate and come in and out over days to weeks to months. I think sometimes we think like, oh, they have an ear infection, you know, you see them again, it looks like it's getting better, that there's just sort of always this track to resolution. But we are monitoring kids really closely who have this, and we see a lot of variability. Kids come in and out and in and out and in and out. And so there's not a good prognostic ability and what these kids are experiencing. But again, if we're getting at least sort of every time you're seeing them a clear picture of what's going on behind their eardrum, we're going to have a much better idea of, do they likely have a hearing loss? Is there some hearing loss associated with this? And sort of what's happening over time. And I think that's really critical when we're thinking about our management. So these images on the right are from some children, a child that we've been monitoring that I just think gives one example of this. And so I'll show you in the next slide some pictures, but we're able to go out into the community and monitor kids who have ear infections weekly to really understand how some of these outcomes are changing over time in kids with fluid in their ears. And so this is a kiddo we were monitoring, and on week 1, you see an audiogram there. And what I want you to take home from this is in the left ear, there's a little bit of negative pressure, that type C tymp, and you can actually see their tympanogram to the right there, that blue tymp in their left ear. And so borderline, a little bit of hearing loss maybe in those low pitches, but overall this child is hearing pretty well, and you see that nice peak on the tymp, and so there's no fluid in that ear, a little bit of pressure but no fluid. In contrast, their right ear you see is hearing more poorly at all the pitches, and in fact quite a bit of hearing loss at those higher frequencies, and you can see their tympanogram on the right, that red one is completely flat. So again, the tympanogram is flat, and you see the associated hearing loss on the audiogram. We went back a week later, and we were really just worried about that right ear at this point because of how much hearing loss we saw the week before, and we didn't have a lot of time with them that day. They had to get into their preschool, but we did a quick audiogram, the hearing test, and then an associated tymp, and they were actually hearing a little bit better that day, but still sort of some notable sort of mild slight hearing loss there, so around 25 dB, and still a flat tympanogram. So things are not normal in that middle ear space, even though maybe things are improving a little bit. We go back for week 3, had a little more time with them, so we did both ears again. You see that left ear again in blue, nice normal thresholds, a nice peak on that tympanogram. But again, that right ear is actually now hearing poorer than it was the week before. We're back down again. We see the flat tymp and that 25 now to 40 dB amount of hearing loss, so down to that moderate conductive hearing loss. So again, the take home here is that all this hearing loss can fluctuate. There's a lot of variability there, but in all the instances, it's pretty clear from the tymp which ear has the problem, very flat, versus which ear is doing okay. And that's the one, in this case, the left ear with the peak. Consistently has a peak at all these visits, whereas that right ear is completely flat. You can go to the next slide, Carrie. And so this is just sort of a shameless highlight, but to show you how we can get these data, but also to underscore how easy it is to make these measurements. So we do this in a van that we drive to kids' houses or to their preschool parking lot or wherever. And so we can take this van out. You can see in that top left picture, I've got the probe, a similar one to what Dr. LaCour presented. It's just a different type of tympanometer. And this kiddo's just playing on an iPad. I pop it in his ear and he's happy as a clam to let me make that measurement. Same one on the bottom, slightly older kiddo. I don't even have to hold it there. She's just playing on an iPad and I can make these measurements. We've actually quantified this in our clinical settings in kids who are at least in ENT being seen for tube placement by our audiologists, some of which are just out of grad school. We are successful in getting tympanometry in 98% of cases. In my lab, we get it literally in 100% of cases. I think it would be very, very unusual for not to get this. And that's not me doing the testing in 90% of cases. These are people who work in my lab. Some of them are audiologists, but many of them are undergraduate students. You know, we can train just about anyone to do these measurements. It's really easy, which is why we're able to go out into the community and make these measurements. Next slide, Carrie. So why might we be concerned about this hearing loss or thinking about this hearing loss? And that's because if you have hearing loss when you are a young child, it can have downstream developmental consequences. So there was a really nice review paper by Witten and Pauly in 2011 that really summarized these data, both in animal models where we can really control what's happening and in children, that clearly demonstrated that middle ear effusion can be associated with deficits related to a lot of different developmental outcomes, things like speech, language, and auditory processing, and that those deficits aren't just necessarily present while the child has fluid. I think a lot of people think like, oh yeah, sure, in this period of time they might have fluid, maybe these things can be a problem, but as soon as the fluid is resolved, everything goes back to normal. And that's not the case. Some of these deficits can persist for months to years, even after the fluid is gone, even after the hearing loss is resolved. And that's because these effusions and the associated hearing loss is occurring during really critical developmental periods. So when we are young and when children are young, our sort of neural circuitry in the brain is developing, and it needs consistent auditory input to develop appropriately. So if during those critical developmental periods, you are having sort of changes in the input because you have hearing loss in one ear, or maybe not the other, the hearing loss is coming in and out, that can really disrupt that developmental process and in turn impact these types of outcomes. So even after the hearing loss resolves, the impact of that hearing loss in the developing brain might persist. Again, the first 3 years of life, we have a lot of information in the literature and from our neuroscience literature has clearly demonstrated that those first 3 years of life are critical for language development. But this is also a period where we see a very high incidence of otitis media. I would say 90% of the kids that I recruit into our studies are under the age of 3. And so again, the timing of that otitis media, the timing of that fluid, the timing of the hearing losses associated with it makes these children at risk for some of these downstream developmental effects. And some of those effects we may never even think about downstream associating them with a history of middle ear effusion. So this can even affect things like behavior, academic achievement, because of sort of these cumulative effects. And you would never see a child, who's 6 or 7, who's struggling behaviorally in the classroom and think, oh, that's because of your history of otitis media. But that's why we're kind of trying to do these studies to really closely monitor these kids, because we do have evidence that these are potentially linked to each other and likely associated with each other. You can go to the next slide, Carrie. So this is from that review paper I mentioned from Witten and Pauly. I could spend the next 6 hours talking to you about all the potential downstream developmental effects, but I think it's a really beautiful summary that I just wanted to sort of highlight, again, big picture take home of how many outcomes can be impacted by this. So this review paper, again, looked at tons of different studies, and you can see them listed on the left there. These specifically are studies that not only monitored if a child had fluid in their ear, but if they had hearing loss associated with it. And we do think that that's a really important link, that the kids who maybe have a little bit of fluid but no hearing loss, or probably have closer to that type A tympanogram, are probably a lot less at risk for these downstream developmental effects. So this sort of these studies sort of consider that. And so you can see they looked at outcomes in speech, both perception and production, and language, both receptive and expressive, and various perceptual and physiologic objective measures of auditory processing, and cognitive abilities, and academic sort of outcomes and abilities. And what they're showing in the table is sort of what outcome measure they looked at, and if there was a significant effect due to OME or hearing loss. And you can see a lot of bolds there, and anything that's bolded was a significant effect. So across all these different domains, we have evidence in the literature that OME and the associated hearing loss can cause deficits downstream even after the OME has resolved in these children. And there's one consequence that I really want to highlight, because we have quite a bit of evidence in the literature of the effect of OME on it. I think it's one that's pretty clearly been demonstrated repeatedly to be a downstream consequence. And it's one that I think is really important as it relates to kids. So Carrie, you can go to the next slide. And that's something called binaural hearing or binaural processing. So binaural hearing really thinks about how our two ears work together. And so we, sometimes we talk about, well, if you have one good hearing ear, you've got enough hearing to develop speech and language. And that's probably true. But our brain really relies on input from both ears to do two really important things. And that's figure out where sounds are coming from, or localized sounds, or understand speech in noisy situations, like a noisy classroom, like our kids are learning in. And so, if a sound is coming, you can see in this image, if a sound is coming from in front of you, it's going to get to both ears around the same time, and it's going to be probably about the same loudness when it gets to both ears. And our brain can sort of compare the input in two ears to figure out, oh, same timing, same loudness, it must be coming from in front of me. Whereas if a sound is coming from over here, it's actually going to get to this ear quicker than it gets to this ear. And your head actually creates sort of a shadow effect as that sound tries to travel to this ear. And so it's softer in this ear, and it gets there later in time. And even though these are kind of on a very, very, very small sort of amount of level difference and amount of timing difference, our auditory system is really impressive at how it's able to compare that. And so those slight differences in timing and level, it can say, oh, the sound's coming from over here. And it also uses those similar types of properties to kind of filter out background noise. If you're trying to listen to it, if a kid's trying to listen to their neighbor in their classroom who's sitting to the left, it's still using kind of those similar inputs to sort of focus on that and remove sort of some of the background noise. So this is a really important sort of auditory processing ability in children. And we see evidence in the literature in kids for months that the deficits in this can persist for months to years after the OME results. We also have quite a bit of evidence from animal models where you can actually put fluid in the middle ear or put an earplug in and sort of monitor them very precisely. So sometimes it's hard to do these outcome measures and monitor things very precisely in children. And so we have studies in animal models too that also suggest that this is a very clear downstream potential consequence of OME. And in fact, in addition to sort of behavioral measures where we test kind of the ability to localize sound or understand speech and noise in kids with a history of OME, there's also evidence in their actual brainstem responses and their physiologic and electrophysiologic responses. So we can put electrodes on and play some sounds and see how the brain is actually responding to sound. And we can see differences in things like the interpeak wave latencies and the absolute wave latencies in these brain neural responses that suggest that their neural conduction is different in kids with a history of OME. So it's not just that behaviorally we see this, but we also see evidence like in just how the brain is processing this sound that we can attribute to that history of otitis media with effusion. And so again, if you have deficits in binaural hearing, this would make it harder for children, again, to localize sound, to understand speech and noise. And it makes a lot of sense when you think about it, that this would be a downstream consequence. Because if you imagine in their tiny little developing brain, sometimes there's hearing loss in this ear, and sometimes there's hearing loss in this ear, and it's coming in and out. That's a lot for our brain to make sense of when it's just trying to develop and learn. So maybe in an adult where this is a well-established network, it could tolerate that a little bit better. But in a young child with a developing brain, sort of all of the variability in hearing loss because of variation in otitis media with effusion and that associated hearing loss can have these pretty significant downstream consequences. Carrie, you can go to the next slide. So just to sort of try to pull this all together, how then, so we know that it's important to think about the hearing loss associated with OME. How does the tympanogram help? Well, again, I just want to underscore how sort of easy comparing that peak to not peak timp is. So if you see a peak, the likelihood there's fluid and hearing loss there is very, very, very low. If you see that peak tympanogram, you can say, this kid's probably hearing pretty good. There's probably not fluid behind that ear. In contrast, if you see that flat tympanogram, there's fluid behind that ear and there is likely some hearing loss. It could be, you may not be able to tell how much hearing loss there is, but there's likely some. And so if we use that tympanogram to add precision to our diagnostic process, it really will allow us to sort of identify and then track hearing loss risk much more carefully over time. And what I think is the biggest potential implication of this is that then we're going to know what is sort of the most appropriate management pathway for these kids. So in addition to thinking about the antibiotic stewardship, we really want to think about which kids are having repeated hearing loss over time. Those are the kids that need to be referred to ENT to think about tube placement. So if you see a lot of flat timps at these repeated visits, again, the fluid's there, there's likely hearing loss there. But if you don't do the timp and maybe it's a peaked timp, you could be referring kids that actually don't need to be seen by ENT. And so in the US, that process of kind of getting to ENT and tube placement can take weeks to months. And so it's not often, those in some cases, especially in rural areas, it can be a lot longer. The wait times aren't crazy. But in some parts of the country, I talked to colleagues in the UK and Canada, in Australia, the wait times for tubes or grommets can vary widely from weeks to months to years. And so the resources are just different in different locations. And so adding that tympanogram adds so much precision to the diagnostic process that can really allow us to identify these are the kids that need to be seen by ENT, but also conversely, these are the kids that maybe don't need to be seen by ENT, that we can keep them in primary care and watch and wait. And sort of those are going to be the kids with the type A timps. And so this really ensures that children who need consideration of surgical management can get that sooner. And that we really add, again, that precision to our diagnostics. So hopefully the kind of cumulative information about antibiotic stewardship and the importance of hearing loss is driving home how just adding this really simple, easy to make measurement in addition to otoscopy can improve your diagnostic precision and outcomes ultimately in kids who have ear infections in your practice. So I think the next slide just closes us, Carrie.
Yeah, great. This was wonderful. Great information. I really appreciate you taking the from the diagnostic perspective to the clinical management perspective, and then also to the, how this impacts children's development and all of those types of things. So we do certainly have a Q&A time. If anyone would like to ask any questions, we're happy to answer them. I do have one initial question that I'd like to ask. So how difficult is tympanometry to incorporate into a practice? And either of you can add information here.
I'm happy to start. So I mean, and we both have talked about how frequently we do this. I think it is really, really simple. I think it's with any new tool, there's always a little bit of uncertainty and hesitancy. But I think if you just start doing it, you'll realize how simple it is and how well tolerated it is. So again, we have quantified this and we get it about 98% of the time in our clinics and 100% of the time in my lab. And again, that's not always by people who are highly skilled ENTs or audiologists who do this every day. Like I have trained young undergraduate students to kind of everyone in between. And so, it doesn't have to be necessarily the primary care provider or the pediatrician doing the measurement. I think it's very feasible that a nurse or a nursing assistant or a PA or an NP or whoever sort of in your pipeline, wherever that makes sense to do it, could be easily trained to make these measurements and then provide that information, just like they would provide a blood test result or any other lab test or a vision screening. We do so many types of these measurements already in primary care. So I think it's a very easy and simple addition. And I would say, again, we get it in most kids. So most kids tolerate it really well. Does a child occasionally cry or wiggle? Sure, they do when we do otoscopy too. And so I see no real significant difference in doing the tympanogram versus doing otoscopy. And like in the example Dr. LaCour shared of that little 1-year-old, like I will often be able to get this easier than I can get a clear view of an eardrum in a kid.
Yeah, and I'll just second that. Basically, yeah, I will have our assistants do it before some clinics have the assistants do it before the provider even gets in the room. So the data is waiting for the provider when they get in.
Yeah, I don't know, Dr. LaCour, can you share with you your situation or your team, your nurse practitioner when she was new to your practice and started utilizing this based off of your passion towards utilizing this within your practice? I love that story that you share with us.
Yeah, so she was new to ENT and she was using the tympanometer like 5 or 6 times a day. And she for the first week, it took her about a week to get comfortable with it, but that's it. And then she's like, I think I'm missing about 100% of my diagnoses. And now it's so cool because now she's been with this for several months and she's like, okay, I'm getting more accurate with this. And that's what's cool about it is the more you do this, the more your otoscopy skills will get better because what you thought was fluid wasn't fluid. And then you're like, what did I miss? Right. So your otoscopy skills will grow as well just from using this. But yeah, now she's like super confident, but she still loves the tympanometer. So.
Excellent. So the next, you kind of answered the question, but how do children tolerate tympanometry? But I think you've kind of mentioned that throughout the presentation as well. One of the questions was, so I see, Megan, you have your hand raised. If you could type into the chat your question. I just don't know if I can add your microphone to the presentation, and due to the technical difficulties I've already experienced with this presentation, I would prefer if we could just answer your questions. We definitely want to get to that. So, so one of the questions was, do you also train other personnel to interpret the tympanograms?
Yeah, so one of the relationships my company, Compassion Medical Education, has with MAICO is that when a MAICO device is purchased, you get seats to our courses. So I have online courses where my team trains the providers like when to use it, how to use it, what the tracings mean, and we have an audiologist as well that gives tips based on some things they might encounter. So it's very straightforward. And then you have access to myself and the audiologist for any problems down the future.
Great. Let's see. Dr. Merchant, maybe you want to comment on this. Could you please comment on ipsilateral acoustic reflexes and also OAEs?
Yeah, so these are other sort of very commonly used audiologic objective measures that we use in clinic, both of which would likely are going to show differences in kids who have fluid in their ears. The OAE takes a tiny bit longer than a tympanogram, but I have actually been in primary care clinics and worked with pediatricians who use OAE instead of tympanometry or some combination of those two things, because it does tell you something about inner ear status in a lot of cases. So some places will use OAE screeners. The effects of like something happening in the middle ear, like fluid, versus a hearing loss in the inner ear, are a little more complicated to distinguish with an OAE. And so we could have a whole nother lecture on that, but certainly another tool that could be used to give us a better indication of what's actually happening, at least with respect to sound transmission in the middle ear, and if there's fluid there. And again, same with the acoustic reflex. You know, the acoustic reflex requires a very loud stimulus. And so I find that some kids don't love that. I can get it in a lot of kids, but you have to make a very loud sort of sound in order to see if that reflex activates. Whereas the tympanogram is a softer, sort of more comfortable volume sound, and a little more straightforward to interpret. And so I think it, in terms of the primary care setting, is probably a more ideal measurement. And there are certainly a number of brands and devices out on the market, but I think what I love about the MAICO devices is that they're so simple and easy to use. And so they're very sort of pediatric office friendly. And yeah, so that would, I guess, given where we're presenting with, maybe that feels a little biased, but even as someone who has used all sorts of different devices from all sorts of manufacturers, some of them are great for like more complicated diagnostics that we use in audiology and ENT. But for a screening tool and something really simple and straightforward, I think they're perfect for a pediatric office.
Great. We appreciate that plug. But so there, another question is, as an educational audiologist, we will monitor students with middle ear fluid to be sure we are providing accommodations for auditory access. What is done medically for those children that don't necessarily have an infection, but do have persistent fluid and resulting hearing loss?
Yeah, first of all, it's a great question. Second of all, I love that you're kind of thinking about auditory access in these kids that you're following. You know, at least in the US, I think when you see persistent fluid without infection, those are the vast majority of kids that are getting tubes placed. Even when you're seeing recurrent acute otitis media, often by the time they get to ENT and get the tubes placed, we actually were doing bacterial assays on fluid that we collected during surgery. We don't see a lot of pathogens present. In some cases we do, but by the time these kids get to ENT, it's often more OME than AOM. And that's in part because they've been on, we know that they needed antibiotics, they've been on antibiotics, we've found the right antibiotic. And so at that point, it's the fluid that's persisting. The eustachian tube isn't functioning right. And that persistent fluid was getting infected repeatedly, hence the AOM. And the tubes are a very appropriate treatment option for resolving that fluid. And in turn, there's no fluid to get infected. And so we resolved the AOM as well. In other parts of the world, I've talked with a number of providers. You know, when you have kiddos that don't have access to tubes or grommets for years in some cases, thinking about their auditory access is really important. There are places around the world that are considering fitting these children with hearing aids, both air and bone conduction, I've heard. And I think there are pros and cons to both of those approaches. But I do think, you know, again, thinking about that auditory access, and if a child has a 30, 40 dB conductive hearing loss for months to years, you know, again, really significant potential effects on downstream implications. So thinking about how we can get them auditory access if tube placement is not appropriate. I'm not sure, Dr. LaCour, you might have other thoughts on sort of management.
No, you nailed it. I mean, it's like, it's one of those things where we have a low threshold. I'll see them back after a few weeks, like maybe 4 weeks or so, and have a low threshold for tubes after they've been on antibiotics and steroids and things like that. It's like that fluid, you can, I mean, if to your point, oftentimes the fluid's not going anywhere. Like if it's just, it's kind of an acute thing and they had an upper respiratory infection, they happen to get acute otitis media or have some residual fluid, yeah, that may resolve on its own. But those that are frequent flyers and yeah, a lot of times that fluid just stays in there and they need tubes.
But again, I think that's why the accurate diagnosis is so important, because you could see if someone has a funky eardrum or some weird, you know, laryngoplasty on their eardrum or things that make diagnosing it hard, you can't track how frequent the actual fluid presence is. And that's sort of the critical piece to knowing if we need to send them for tubes or not.
All right, perfect. How about, can you differentiate between type B and type C tympanograms in children? You didn't mention type C tympanograms that showed negative pressure. I think you briefly mentioned that, Dr. LaCour, when we were looking at the different graphs and what they look like, but can you provide any additional information on that?
Yeah, so when I see a type C, And I think Dr. Merchant's data showed it as well, that you can have a little bit of hearing loss with the type C. That just means that the eardrum is sucked in and it's not moving as well, right? So you may have a slight conductive loss. I will see those children and I'll see them back in several weeks. And if they keep a type C tympanogram, I will get a hearing test on them to make sure it's not affecting their hearing enough to warrant ear tubes, right? Once you get greater than like -175 on the pressure, you start seeing some hearing loss. So I will track those kids. So if I'm in primary care and I'm tracking them and I see a negative whatever 175 or it's type C, and then I see him back, a month later and it's -50. Well, that's a really good sign, right? There's much less pressure, much less likelihood of having a hearing loss versus type B. Type B is I'm hearing loss until proven otherwise, right? And so that I hope that helps.
Yeah, the kind of a follow-up question to that was really share your recommendation for follow-up of children with the negative pressure. So do you wait or do you retest or what's
Yeah,
best
I'll see him
practice?
back. Yeah, I'll see him back in about 4 weeks. And I want to just repeat and see how they're doing. If they're heading in that right direction, that's great. I will keep seeing them until it pretty much resolves. And then if I'm not certain, I will get a hearing test. And so if I know some of my children are living with -50 or -100 pressure, but they don't have a hearing loss, then they're good. I'll just keep an eye on them so long as they're not developing fluid. But yeah, I would say I usually give them about a month at a time to kind of resolve and to get better. If they need like an antihistamine or something like that, or some of them need a nasal spray to help open up the eustachian tube, we'll do that. But yeah, I usually about once a month. But then again, I would send them to ENT. If they're consistently negative, then I want to make sure there's not a significant hearing loss from that type C tympanogram.
Great. Dr. Merchant, with your passion with wideband tympanometry or reflectance, so one of the questions was, can you talk a little bit more about that? Can you just kind of give us a little bit of an introduction on what that is and utilization of that?
Yeah, so standard tympanometry, which is what I've been talking about, uses in most cases, a low-pitch stimulus to see how the eardrum is moving. We've used it in clinical practice for 50 plus years, and it's kind of our tried and true. Wideband is an advancement on that. It's very similar in terms of how you make the measurement, but instead of using that low-pitch stimulus, we're using a wideband click stimulus, which includes frequency or pitch information from the low pitches all the way up to kind of the higher pitches. And so we just get a little bit more information about sort of the how the eardrum is moving and how the middle ear system is working across that range of frequencies. So, with respect to what I talked about in terms of how the hearing loss can differ with the amount of fluid, you from wideband tympanometry are going to be able to get a bit more information about like how much hearing loss might be present. And so, again, I think making that step to at least knowing definitively fluid, no fluid is a really, really important and very clear-cut interpretation and step we should be making in primary care. If I see wideband tympanometry maybe downstream once we're all doing that as standard of care as a potential advancement of that. It's something we are starting to use more in audiologic and ENT practices where we're thinking about sort of the next step of our diagnostic. So now we know there's a problem in the middle ear, the tymp is flat. How do we understand that a bit better? What the real implications of that are on sound transmission and thinking a little more nuanced about management. And that's where I think wideband tympanometry is coming into play. So it's basically, I think about it like the next step, the more advanced diagnostic step from standard tympanometry, but much newer. It's just really now sort of on the cusp of making its way into clinical practice. So I think how it's going to influence management and where it's going to land and where it's going to impact the most, I think we still have to kind of figure that out.
Excellent. Well, we're kind of coming up to the end. I wanted to put some contact information on the screen so that if there is a question that we did not get to, or if you think of a question later on, or you're reviewing this presentation later on as well, and you'd like to get in contact with Dr. LaCour or Dr. Merchant, that we can answer your question. I have my contact information there. Certainly reach out to me and I will make sure that we respond to you and get the answers to your questions. If there was any questions that we did not answer within the presentation, presentation, certainly we will review those and reach out to you as well. I really want to thank everyone for joining us for this World Hearing Day presentation. I really want to thank Dr. LaCour and Dr. Merchant for your time and giving us this information. It was so beneficial. We hope that everyone found truly some value add or some benefit to hearing what they had to say and what's part of their practices. So thank you, everyone. We appreciate your time and have a wonderful day.
Thanks, everybody.
Thanks, everybody.